Great.
Finally.
Okay. So I hope you can see my slides and, of course, hear me as well. It's really a great pleasure to be in front of you all and to share about something about which I'm really passionate about. I'm working as a consultant cardiologist at Bedfordshire Hospital NHS Trust, and my subspecialty interests are in arrhythmia. So I happen to be a board certified electrophysiologist as well. And that's why I will try to give you some of the emerging concepts as well, how ER can be a bit more dynamic for the treatment of EP or arrhythmias as well. Okay, and I will try to show you a lot of examples as well, because examples is something you all have to come across as well and face them. So, so these are the subheadings under which I'm going to talk about. We'll try to go through a lot of examples. As I said, it is. Does anyone recall who is he? So he is Eindhoven. Eindhoven is the one who did one of the world's first ECG as well. I did my EP training just at 1 hour distance from that city, which is named as Eindhoven. It is called as Maastricht, where the father of modern cardiac electrophysiology had been there, Professor Hein Wellens. I think you might already been aware of what is called as Wellens sign on ECG, right? Okay. So things have gone quite a lot far, I would say, especially in the last century. Now you don't need so many big boxes and all to be able to record the ECG. Now you can even use your smartphone and also use a unipolar recording using a smartwatch. Interestingly, being an electrophysiologist, we have tools now with which you can visualize those arrhythmias. And you can even visualize the propagation, how the arrhythmia is going around in the heart. And the latest development is what is called as a non-contact mapping as well. So you can put up a jacket, you can put them around a machine, and you will be able to see where is the possible source of arrhythmia, and even you can go and ablate them as well. In fact, some of the hospitals around the world, they also have an active ER, or what is called as a heart EP labs. So for example, primary angioplasty is done. Similarly, primary ablation as well is done. For example, for ventricular tachycardias or ventricular fibrillation and all as well, where the mortality can be quite a lot high. So after having a good understanding of the Eindhoven's triangle, which is key to be able to determine the ECG is axis, which is again crucial. For example, if we are trying to deal with an ECG anytime, anywhere, in fact. So for example, if we are aware if there is northwest axis, most likely we have to consider for something like a ventricular tachycardia or a ventricular fibrillation and all these things. So we have to be really, really alert for these kind of conditions. So we all are aware very much about this cardiac conduction system, the sinoatrial node, which goes into AV node, then going to the hills, and finally the bundle branches. So this is an interesting study in which they tried to see whenever the patient is getting admitted, what are the arrhythmias which anyone has to come across. So if we will see it over here, indeed, one of the common things is like atrial fibrillation, incidence-wise may be one of the lowest, okay? However, when it comes to the cost of a economic as well, so for example, any kind of Western economy as well, which we are talking about like the US, the UK's, or the developed countries, a huge amount of it is getting spent for the management of these atrial fibrillation arrhythmias, in fact, because morbidity-wise, it doubles the risk of dementia, triples the risk of heart failure, quadruples the risk of stroke. Now, so any kind of arrhythmia, whatever, when we come across, what happens is there's always a recognizable risk factor. So if we can come across a preventable or modifiable risk factor, that will always be great. If we try to take care of the offending risk factor, we will be able to treat them as well. In fact, as you can see in this list as well, a lot of those medications, you can easily take care of them. And if you will be able to treat those preventable risk factors, you can help the patient to recover much more better and also quite a lot earlier without threatening endangering the patient's life. So I will still like to focus on the main content. However, we need to have a little bit of understanding of the mechanism of arrhythmia. How does it happen? Because on the basis of this mechanism, we can determine its cause and also finally the treatment as well. So one of the first common cause is automaticity. So here, the resting membrane potential increases the phase 4 depolarization, lowering the threshold potential. For example, there will be increased sympathetic tone, there will be hypokalemia or even myocardial ischemia. So there are other mechanisms as well, like the triggered activity or even the reentry. Triggered activity refers to the oscillations in the membrane potential after an action potential. So there is early after depolarization. So the arrhythmias will typically include something like a torsades de pointes, which will be induced by like drugs or even digitalis or catecholamines as well. Or reentry, I think you all are very much aware, something like a AV nodal reentry, AVRT, which is mediated quite a lot often by the accessory pathways as well. Now, coming to something, let's get our adrenaline surge kicking and going. White QRS tachycardia, I think we all get under pressure whenever we all are coming across and all. It is always very important to be able to understand what is the differential diagnosis. So most commonly, diagnosis for the white QRS tachycardia is ventricular tachycardia. In fact, more than 80% of the times it is ventricular tachycardia. However, 1/5 of those arrhythmias can have other arrhythmias as well. Like, anyone would like to help me giving a differential diagnosis? I would like it to be a two-way conversation rather than just one way. Anyone would like to suggest what are the other arrhythmias as well? So it's already written in the slide as well. If you will see, supraventricular tachycardia is like with aberrant conduction, pre-existing bundle branch block, or even the ones with accessory pathways. So for example, if there's with Mahaim or even bundle of Kent as well, right? So it is very important for us to be able to diagnose it. How do we diagnose it? So you should have really get alerted if we all come across, if someone is having a history of myocardial infarction or ischemic heart disease. 98% of them, it will be ventricular tachycardia, okay? Or similarly, if one has a structural heart disease or there is impaired LV systolic function, then what you can also try to do is, if on doing the clinical assessment of the patient, if the patient is safe enough, you can try to do what is called as a provocative measures, like vagal maneuvers, or the modified Valsalva maneuver as well, or the carotid sinus massage, or even adenosine as well. I'm sure you all would have come across. And then we try to go for the other tools and technologies. Tools and technologies, I mean, is the ECG. On the ECG as well, we will be going through further more details as well. So initially, you try to see what is called as a capture beat or a fusion beat. And also, what about the AV dissociation? Of course, if you see the P waves are not correlated to the QRS, so that is when you may start thinking of the ventricular tachycardia. Similarly, if you see, okay, there's an arrhythmia, but it seems like it is becoming irregular, it could be most likely SVT. Then similarly, you try to see for the concordance. If there is a positive concordance or there is only a negative concordance as well, again, you will start thinking of ventricular tachycardia. Similarly, QRS duration as well. So white QRS tachycardia, we already said it, most oftenly is ventricular tachycardia. Similarly, the QRS morphology. QRS morphology, I mean, is does it have a bundle branch block? Is it having something else? So now coming about the narrow QRS tachycardia. So there are different ways in which you can divide or differentiate or distinguish those different arrhythmias. Either it could be bradycardia versus tachycardia. Similarly, tachycardias as well, you can again divide into narrow complex tachycardia if the QRS width is less than 120 milliseconds. And of course, if it is a tachycardia, means the heart rate is more than 100 beats per minute. And so, of course, if one is a narrow complex tachycardia, the other group will be wide QRS tachycardia. So in the narrow QRS tachycardia or narrow complex tachycardia, one of the simple type is what is called as, on the basis of RP intervals, you can differentiate, is it a short RP interval or is it a long RP interval? So if you look carefully, this ECG which is there in front, you will be able to notice that here, if you try to look out for the P interval, you can see those big P intervals, isn't it? They're not T for sure, okay? So here, the RP interval becomes pretty long. However, if you look over here, the R interval is the P, I would say, the P wave interval is almost merging with the QRS complex. So this is what is the short RP interval. Short RP interval, you will have to, there are a lot of complex maneuvers as well in EP we all have, but I don't want to confuse you all. And in the limited time, I would like to touch base with the most common things. Okay. So that's why if there is a short RP tachycardia, you should try to think of for AV and RT. However, one thing remember in life, medicine is a field of exceptions. Higher you go in your quest of knowledge, more and more exceptions you will come. So during your medicine time or maybe during your earlier times of your residency or specialty training, you will have heard like short RPs, AV and RT. There is a type of AV and RT which can be even long RP tachycardia. Let me try to enter. Someone is waiting. Okay, CETA. Okay, so yeah. So yes. So as I was telling you, so what is called as atypical AV and RT. What is called as fast, slow AV and RT. That one can have long RP tachycardia. But as I said it, I don't want to confuse you all. Try to have simple concepts which will make it easy for you all to distinguish the arrhythmia. Short RP tachycardia, try to think of the ORT, orthodromic reentry tachycardia, or the AV and RT, as I said. Similarly, the long RP tachycardia, we all know, sinus tachycardia, or of course, it can be atrial tachycardia. So, how to approach? So, I already gave you an example, the RP wave, or you can also do any of these maneuvers which I was talking about. If you give adenosine, so adenosine, we should know that yes, it will terminate most of the reentry tachycardias, and you will be able to see the P wave. So that will be further helpful. That is it a flutter, or even like sometimes for atrial fibrillation as well, or even if it is SVT or what type of SVT as well, it will be further helpful. Okay. So now coming to the management, I think everyone is interested in the management part. What or how to do about the management part? We still follow the ACLS protocol. The ACLS protocol still tends to hold true majority of the times, I would say. So if it is unstable, signs of hemodynamic compromise are noticed. So what are those signs? Anyone would like to share? What makes you feel that patient is hemodynamically compromised? Wonderful, very good, very good. Similar, as you already said, like hypotension, heart failure symptoms, or end organ dysfunction. So that is one of the time you have to be really be alert. You have to be quick in making those decisions. If needed, you can sedate them or give some formal anesthesia, and that is the time you can even consider for DC cardioversion. And if it fails, then in the meantime, as I said, try to immediately go through the ACLS protocol, thinking about the reversible causes, take care of the SpO2, acidosis, potassium levels, magnesium, if needed, again shock, and of course try to go for the antiarrhythmic drugs and all. So now coming to the adventure room. So you all are there in the ER. So a paramedic comes to you. Hey, look, this is a 60-year-old guy. He had a myocardial infarction just 30 minutes back. We had seen the ECG and all. Uh, but right now we did the ECG. This is what it looks like. What do you think so? Anyone would like to try? Wonderful. Very good. Very good. Yes. What else?
Secondary TA change, there's no primary TA change.
I can't hear very well, but so few things are very much clear. Very good approach as well. Uh, it is indeed a YQS white QS, morphology. It is in the form of left bundle branch as well. What else? Can we see the P wave over here?
The ventricular escape rhythm.
It is difficult. So, especially what happens is one thing we should keep it in mind, especially in patients of myocardial infarction, and in the initial few hours, what is called as perfusion injury. So, it is characterized by what is called as a idioventricular rhythm. And as if you will see over here, this is not a tachycardia. I know it is difficult to have an estimation of the heart rate. So, this is what is called as accelerated idioventricular rhythm. Okay, so no need to do. So this means it's a sign of good reperfusion. So no need to do anything. Just observe. If there is anything needed, you just give them a supportive treatment. Okay, wonderful. So you guys did an awesome job. Next day, what about this patient? What is happening over here? So for example, I would say like 45-year male patient uh, with this ECG comes, panting, gasping for breath. Doc, doc, save me, save me. I'm not feeling good at all. What is happening?
Is it case with fast ventricular response?
Very good, very good,
With a broad complex tachycardia and irregular. Yeah.
very good, very nice. See, we have so much brilliant minds. I'm so proud of you all. Wonderful. What else? So, what should we thinking of?
The cardio him.
Sorry?
The cardio him. If he's coming with chest pain and signs of failure.
Diagnosis.
Yes, with a bundle branch block. Yeah.
Okay. You're still going in the right direction. Okay. Now, so as you were already talking about atrial fibrillation, so as I said, it is atrial fibrillation is indeed one of the most common heart arrhythmias which we all will come across. And so, what about its management? What happens is, as I already said it earlier as well, always try to find if there's a predisposing cause. If there's an underlying cause like pneumonia, electrolyte imbalance, or ischemic heart disease, or sometimes even during, other problems as well, try to take care of that. So if it is a pneumonia, of course, if you are able to take care of the infection, you will be able to help hopefully resolve this arrhythmia as well. To tell you surprisingly, you all are working in ER. You know how much is the incidence of atrial fibrillation in post-COVID patients after recovery? Studies have shown up to 20 to 25% of those patients will develop atrial fibrillation sometime or the other. So there will be a big epidemic of atrial fibrillation which will happen, or of course the heart failure as well, similarly. So those patients, you come across this, you took care of the reversible factors, then coming to the anticoagulation. You all are already masters, like how to use the stroke risk, okay? What about the bleeding risk according to NICE guidelines? Which scoring do you use? No, I'm not happy. I'm not happy. Come on, you guys are disappointing me now. You know what is the NICE guidelines has said it, and I'm even doing an audit. What has they said it is NICE guidelines last year itself. Um, we should use what is called as the orbit score. So orbit is a new score, and why I'm trying to tell you all this. Even in the expert consensus document on AF ablation, my two papers are referred. Okay, so orbit, especially being if you are practicing in UK, I would really like you all to use this score. Hasbled is an excellent score as well, but being in UK, we should adhere to the NICE guidelines. And as I said it, the NICE really tries to see as well how many people are following their guidelines and all as well. And we don't want to let down our trust. So that's why it is very important. So as I had said, comorbidities wise, I had already emphasized in simple lines. I think you all should keep it in your brains. Never, never, never forget that. Doubles the risk of dementia, triples the risk of heart failure, quadruples the risk of stroke, quadruples to 5 times, so like this. So the way in which hypertension is there, diabetes is there, in fact, atrial fibrillation is also there. And its implications, as I said, it can be huge. So don't miss that. Don't miss that. It is very important. So one thing, a lot of times we get confused, like, okay, this patient is there, we saw everything and all. Shall we cardiovert or shall we go for the rate control? So in simple terms, if there is the arrhythmia episode, the AF episode, you are knowing like it is less than 48 hours, that is definitely one of the time you can try to think for a rhythm control. Rhythm control, for example, you can even consider cardioversion as well, using a pharmacological method or even DC shock as well if you want. However, if it is more than 2 days, more than 48 hours of duration, that is one of the time you must consider minimum 3 weeks of anticoagulation. Why?
Risk of stroke.
Exactly. Exactly. So one of my other specialty interests is also about anticoagulation. Few months back, I also published a study, what is called as U bled AF study. Try to Google it, U bled AF study, and Kumar or Dr. Kumar or something, or Narendra Kumar. So it was about uninterrupted usage of edoxaban in atrial fibrillation patients. So as you already said, it is they will have a high risk of stroke. So at least it's 3 weeks or even up to 4 weeks as well. Anticoagulate them. Then in the meantime, what you can try to do is you can try to give them drugs, pharmacological therapy, digoxin, beta blockers, verapamil, amiodarone, and then finally maybe if you would like, then consider for BC cardioversion as well. What about atrial flutter? So atrial flutter. So one interesting thing I'll tell you: if even if you have treated any of the atrial fibrillation patients, 25% of them will develop atrial flutter in the time in future. Okay. Similarly, and vice versa is also true. Similarly, if atrial flutter patient is there, it has come. We have ablated that. Even after ablation, 25% of them will develop atrial fibrillation. So you have to be watch out, or you have to be careful as well that okay, flutter is there. They may also develop atrial fibrillation as well in the future. So coming to the management wise and all as well, you all are aware you can consider something like a beta blocker or maybe any of the antiarrhythmic drugs as well. And yes, if the patient is unstable, you can consider them to give a cardioversion as well. What about this interesting ECG? Anyone would like to try?
Atrial dissociation.
I can't hear well, sorry.
AV dissociation, the P and Q are solved.
Okay, okay. AV dissociation, you think? Okay, nice, okay.
Or it could be a MAT too, multifocal atrial tachycardia.
Very good, very good. Why is it I'm hearing only one voice? What about others? We have so many smart and intelligent people. Very good, very good. I really like it. So as you already said it as well, you look carefully and you could see, I'm sure, at least more than 3 different P wave morphologies. And that is where the confusion will come. One of the common confusion few people can have is like, oh, is it a complete heart block? Is it, is it a atrial fibrillation? However, if you look carefully, as you can see it over here, I'm trying to point out my arrows as well. These are the different P wave morphologies. Are they not different? See, for example, over here, this is more like a tented one. This is slightly broad, and this is like a normal P wave. So there are more than 3 P wave morphologies. Okay, the PP interval, the PR intervals is all varying as well, and most commonly you come across these patients with history of pneumonia or even with COPD. In fact. So in that, always the simple thing is try to treat the underlying cause. And verapamil is definitely a great medication for that. And you may consider something like a beta blocker and all as well, but calcium channel blockers or even antiarrhythmic drugs are better for that. Okay. Now, so okay. What about accessory pathway? So we all are aware about WPWs and all, Mahaim pathway, LGL syndrome and all. So what happens? The ECG, if you all may remember or recall, we saw that the wide QRS tachycardia with varying RR intervals and all. So that was the one with atrial fibrillation with accessory pathway. Why? What makes you think that it is the atrial fibrillation with accessory pathway? Because atrial fibrillation rarely can go so fast, so broad, such a broad QRS complex tachycardia, which we had shown. If you see that, never forget time to, you know, uh, be in action quick. You must be quick. Otherwise, such patients will deteriorate quite a lot quickly. So for such patients as well, accessory pathways, so you were lucky, for example, if there was another patient in which the patient has accessory pathway, you saw the WPW and all those things on the ECG. And later on, it came to the when you were on call, like, okay, the patient is having a palpitation episode. You saw that. So what are the medications which you will consider to give during the ER management? Medications I'm asking first. So my question was, you know that this is a known case of accessory pathway. You saw on the ECG is being done, so you can already see the heart rate is like 170 beats per minute. Patient is stable enough. What kind of drugs will you prefer? So in this, a clear concept should be is accessory pathway or AVRTs are the ones which will be going through the accessory pathway, okay? So there's no AV nodal blocking mechanism over there. If you will try to give anything which will be blocking the AV node, something like a beta blocker, something like a calcium channel blocker, you will be promoting the conduction through the accessory pathway. Never do that. It will be a big blunder, okay? So that's why ideally you can give as a antiarrhythmic drug, okay? That is the concept for that. Even in that, try to avoid, I would say, like something like a amiodarone. Amiodarone is a antiarrhythmic drug which tends to have action of all the antiarrhythmic drugs groups as well. So it can also act sometimes a bit like AV nodal blocking agent.
What will you
Okay.
give this patient?
Sorry.
What do you prefer to give them? What's options?
Sorry. Your voice is not clear.
What will you give in the treatment wise for heart rate?
Indeed. So if yeah, so I will prefer to give something like a flecainide.
Flecainide, okay.
Yeah. Okay. Now, how about this drug? What do you see? I must tell, this is a very interesting ECG.
Looks like a paced rhythm without capture.
Uh, Paced rhythm. Where are you notice? No, don't get worried. These spikes, these are those normal, on the ECG standardization kind. Standardization is over here, but sometimes these are not paced spikes. Let me clarify, okay?
Is it a,
So you can.
a junctional rhythm with a complete AV block where if the baseline is could be AF with a complete AV block causing a junctional rhythm?
Very good, very good, very good. Very good approach. As you already said, it is indeed. The RR intervals looks to be pretty constant, isn't it? Okay, the QRS is also wide. It looks like a left bundle branch block. So one thing what I always try to do is, if I'm feeling confused or lost, for the P waves, if you really want to look at lead 2, maybe lead 3, or V1. So these are the leads which will give you the maximum or the best P waves. So if you will look carefully over here in the lead 2, if you look carefully, there's a rhythm strip as well. See, I'm such a nice person, isn't it? I want to help everyone. and even in V1 as well. So these is what is called as fine fibrillatory waves. They may be sometimes difficult to see, but if you look really carefully, so that is why it is a complete heart block with atrial fibrillation. So let's make the life more exciting, right, of the ER physicians. So what is happening over here?
This is a short PR. I'm not able to comment on delta wave, but the PR is quite short. Could be a
Yeah.
W.
Okay, okay. So if you look carefully, as I said, I'm a very nice person, self-proclaimed nice person. So if you look at this rhythm strip, there's a rhythm strip as well. So PR interval seems to be pretty long enough. However, I think you were going already in the right direction. If you look over here, look at this. What is happening to T wave or the ST segment? It is almost getting flattened, isn't it? And later on, so you all were there, very smart. You guys did the electrolytes and all, and you saw it was hypokalemia. Now, one of the things as well, which we all get scared sometimes, is about the bradyarrhythmia. So bradyarrhythmia, the important thing is when to treat, when not to treat. So what happens is we always have to be able to clinically assess the patient. So is the patient symptomatic or not? If the patient is symptomatic, even if the heart rate is around 50 beats per minute, 60 beats per minute as well, do not hesitate, go ahead with the treatment. So for example, symptoms are there, risk of asystole is there, similarly, morbid type 2 or complete heart block with wide QRS, or if any pause more than 3 seconds during the daytime, okay, or someone is having a hypertension or hemodynamic instability and all, or the heart rate is less than like 30 beats per minute, that is the time you have to start thinking of try to consider immediately using the ACLS protocol again for the atropine, isoprenaline, or maybe the external pacing or the transvenous pacing as well. So a lot of times it is not easy, I would say, really. Uh, Even in sometimes really in the EP lab as well, where we put those catheters inside the heart, the patient is there and all. Sometimes it can be really difficult how to distinguish between the supraventricular tachycardia or the ventricular tachycardia as well. So I had already given you the algorithm. I tried to share like what or how you should try to see as well. And so this is a nice chart in which we can see how to distinguish. And I had already given a little bit of the pointers, for example, for the ventricular tachycardias and all, like if there's dissociation, if there's only, concordance is there, either all positive, all negative, or the QRS looks fragmented, and otherwise if there's a patient, or if someone has responded to a vagal maneuver or Valsalva maneuver. But as I said it always, medicine is the field of exceptions, my friend. So higher you go, more you come across, these exceptions. For example, in this we are talking like, vagal maneuver, so adenosine as well. Can you tell me wide QRS tachycardia or ventricular tachycardia type which responds to adenosine, which may respond to adenosine actually? Ventricular tachycardia. So there is a VT type which may respond. No. So it is fascicular type of VT. Fascicular type of VT, the thing is, it will be slightly narrower QRS, in fact. So that's why a lot of times it will easily get confused. I'll show you some examples as well. So about the ventricular tachycardias, as I had already said it, and I'm going to show you more examples. Because the examples, if you see, it will be more in the memory-wise as well, I think. So AV dissociation in the form of capture beats, fusion beats. I'll show you examples of all of them in the coming few slides as well. wide QRS tachycardia, the axis-wise, as I already said it as well. Similarly, if you come across some of the special signs, which I'm going to show you, in fact, in the coming slides. So, for example, in this ECG, if you will come across, what is really happening? I'll give you a simple example. Okay, this patient had a disease in which he was coughing quite a lot. For example, like past 3 weeks, he has been coughing. Okay, what if also he has a history of cancer and he's on treatment for with the medications?
Electrical alternance.
Very good, very good. That's the key. I like it. Very nice, very nice. As you already said it, electrical alternance is there indeed. So this will be pointing like, oh, time for action. Be careful. You have to be, try to immediately get maybe a chest X-ray or a cardiac echo if you can get it. Put the probe, immediately rule out cardiac tamponade. Indeed. Very good, very nice. What about this ECG? What is happening over here? As I said it, I'm a very nice person, so I'll give you some hints. There are some arrows, and there's always a rhythm strip as always. So what is happening is, if you look carefully, these arrows are pointing to the P waves, discrete P waves, yeah? However, sometimes we are not able to see. And sometimes, of course, so what is happening, what is called as AV dissociation. Okay, AV dissociation. However, interestingly, if you can look carefully, it is a narrow QRS tachycardia, isn't it? And if you may look carefully over here, V1 is positive. So this is a right bundle branch block, right? And axis wise is 1 is positive, 2 is negative, AVF is negative as well. So it is left axis. So anyone would like to help me with the diagnosis? It is a fascicular VT. Okay. So that's the reason I didn't want to, put all of them together, because as I said, it will just go away and no one will even remember. So what is happening over here? So I already gave you the example, like I have a rhythm strip down. Have a look over there. That will give you the answer.
Ventricular tachycardia.
Come on, you can do better. So if you look carefully, axis, look at the axis. So axis wise, so definitely it is a tachycardia. Indeed, you already said it. Very nice. However, what is happening over here is lead 1 and 2 and AVF. Both of them are positive. And V1 to V6, it is left bundle branch block. Even in lead 2, if you look carefully, there's always a constant P wave, constant P wave, constant P wave, constant P wave. So this is a supraventricular tachycardia with aberrancy of bundle branch block, you can even call it as, okay? Now, oh, this ECG, we already spoke about it. Now coming to the specific signs. So as I said, it is a common thing for us to get confused, like, oh, is it VT or not? So we will try to speak about some of the special signs which will be helpful, like, oh, it is there, highly likely it is a VT only, or it is not a VT. What is this?
Capture beat.
Very nice, very nice. So whenever there is an interference, the association between a sinus rhythm and a faster subsidiary rhythm, the interference occurs in the AV node. And both the impulses cannot be conducted due to the refractoriness of the AV node as a result of the wave from each focus. At a particular time, the slow sinus wave passes through the AV node when it is no longer refractory and hence conducts down the ventricle. So that's why it will appear as a narrow complex. So that is what is that capture beat. Okay. Now, what is happening over here? So I'm curious to know about the last beat, as you can already see, it is a VT beat, yeah. Second last, I would say like the third last and the fourth last beat. So this one and this one. This is something important. So what are these? They are
Fusion
narrow.
beats.
Very good. So as you may notice over here, the first of the narrow complex is a fusion beat, and the next two are capture beats, in fact. So fusion beats, why is it? Because it is from the fusion of the sinus beat and the wide QRS ventricular beat. So that's why it appears as fused. Let's make our special. What is happening over here now? So there's something which is, in this red calipers, and there's a blue arrow. If you will again come across this thing, if you will see in the ECG, close your eyes. This is VT.
The blue arrow is the P wave, is it?
Okay, you're almost there. You're almost there. So it is actually a notching.
Notch.
So notching, yeah, notching in the QRS is also very important, or few fragmented QRS as well. Fragmented QRS is most commonly present in patients who has had either a myocardial infarction, or maybe sometimes the wide width of the QRS is proportional to the intraventricular conduction defect. But similarly, over here, what is happening is when you try to see the distance, for example, over here, these red calipers, you can see it over here, yeah? So you try to see the distance from the onset of the QRS to the nadir of the S wave, yeah? So if it is more than 100 milliseconds, if you will notice over here, so as I said, it is from the onset of the QRS. So this is the onset of the QRS, right? And the nadir of the S wave. So if it is more than 100 milliseconds, this is what is called as the Brugada sign. And what is something is called as Josephson sign. So if you look over here, there's a notching which is present near the nadir or the fusion of the S wave. So this is again, and of course, if you see both of them, close your eyes and say it as VT. So Josephson sign, Brugada sign. Yeah. So Brugada sign, as I said it, from the onset of the QRS to the nadir of the S wave. And here the Josephson sign is the notching near the nadir of the S wave. Yeah. Okay. This I think you all will already be aware. This is what is called as the rabbit. Yes, rabbit ear sign. So taller left rabbit ear, you'll see it in VT. Yeah. Otherwise, if it is taller right rabbit ear, it's there present in the right bundle branch block. So when do you have to think about SVT with aberrancy? So if you will look carefully at this ECG as well, so starting from the QRS, okay, to the middle of the this. So see over here, if you look carefully, here should be the Q, R, S, and then will be the ST segment, which is starting over here. So as I already said it about the notching in this segment, or even in the S segment as well, which was called the Josephson sign as well, it will be favoring for ventricular tachycardia as well. Yeah. This is slightly complicated ECG, but I'm sure you all can do it. On one thing, I would say in simple words, what we read during the basic, basic medicine days and all, wide QRS tachycardia, whenever in doubt, treat it as VT. Never hesitate that. As I said it, whenever in doubt, okay? So that's the thing. If you are in doubt, always treat a wide QRS tachycardia as VT. It doesn't matter because the life of the patient is more precious than anything else. Whenever in doubt, as I said it, if patient is stable and all, you can take time, you can think about it, you can ask your colleagues and all as well, of course. So what is happening over here?
FTD reference is
Mm-hmm.
strong
Right.
rabbit here.
Good.
There's no erectile axis changes.
So what else do we see? As I said, it will be difficult. So what happens is, one thing I always try to do is, if possible, try to get a sinus rhythm ECG as well, and try to compare the sinus rhythm ECG or the normal without tachycardia and the baseline as well. So if you may notice over here, so can you see over here in lead 3? So there is a very sharp deflection over there, just after the QRS, just after the QRS. This is a patient of AV and RT, short RP tachycardia, yes. So AV and RT with left bundle branch block, indeed. About this patient. And this is one ECG in which whatever concepts I have taught you, if you can use it well, you will be able to diagnose it. So again, what is happening is, let's try to divide it part by part. So if we can see the, the heart rate wise, definitely it is like a tachycardia, right? So if we look at the axis, what is the axis? Northwest, yeah. 1 is negative, 2 is negative as well. AVF is also negative, yeah. So this is northwest axis. And then what you notice is V1 is positive, okay? And there's transition of the QRS in the lead 3. And the V6 is negative. And if now, the biggest hint, you will get it over here. If you look carefully in this, the rhythm strip, what is happening is over here is, sometimes you can see the P wave, sometimes you can see the P wave, sometimes you see the P wave, sometimes you don't. Sometimes you don't. Look at this, whatever segment is there, ST segment is there as well. It doesn't look so uniform because sometimes you see those P waves, sometimes it is not. So this is what is again a case of ventricular tachycardia. What's happening over here? Life is always not so complicated. Life can be sometimes good as well.
Partial.
Right bundle branch.
Okay. Let's do a poll. So how many people think, is it a serious arrhythmia, or okay, the people who think it is a serious arrhythmia or heart rhythm problem indeed, please raise your hands. Oh, the camera is gone.
Nobody. No
Yeah,
raise,
please raise your hands.
nobody raising hands.
Please raise your hands.
Yeah.
Nobody. Oh my God. I'm
Yeah.
so lucky to have such a smart audience. Very good. Wonderful. I'm really proud of you all. See, Bedford, our Bedford patients should be so happy. They are in so much lucky and safe hands. Wonderful. Really? Okay. So this is indeed, as you all can see, this is a sinus tachycardia with incomplete right bundle branch block. I mean, I did not explain. You all are the masters now, by now. So you can already see the P wave is there. Then after that, followed by QRS complex. Then there's a T wave as well, and all fine. Yeah. Excellent. Excellent. Let's make the life a little bit more interesting. So what is happening over here? As I had said, same approach. Try to think the same way.
VT.
Okay. Someone said VT. Why? Why do you think it's VT?
V1 and V6 are all positive, and it's a bundle branch where you can see the left color.
Okay. Point by point. You said all are positive, is it? V1 to V6, you think they are positive?
Yeah, looks like.
No. So if you look carefully, V1 to V4 is positive, but there is a transition at V5. So V5 and V6 is negative. Now, does it change your answer?
No.
No.
Okay, let me try to tell you now further. If you look carefully, lead 1 is negative, but lead 2 is positive. Does it change your answer? Further, if you look carefully, there's a discrete wave. What is this? What is this? Can you notice? Sharp deflection, sharp deflection, sharp deflection. Again. This is the patient which we had taken for ablation actually. So I know the diagnosis very well. So that's why I'm giving you the hints. Sharp deflection, sharp deflection, sharp deflection. This. Retro P, retrograde P wave, retro P, everywhere.
W is it?
AVRT.
Sorry? Wonderful. That's what I was looking for. Very good. As you already said it is. What is happening is the axis is right axis division. 1 is negative, 2 is positive. Right bundle branch block. V1 is positive. V1 to V3. V1 to V4 is positive. But V5, V6 is negative. So this is a right bundle branch block. So it will be a left-sided. Okay? And it was a left lateral accessory pathway, left lateral free valve accessory pathway actually. Okay, good. What about this? What is happening here?
Pace rhythm.
Very nice. Okay, now my next level of question will be is, what type of pacemaker do you think is it?
Unipolar, is it? It's a ventricular pacer, single channel.
Very good. Extremely awesome indeed. So as you already said it, as if we will look at this pacing complexes, they are pretty wide. And this is the reason he thought if it is a unipolar, because unipolar pacing complexes, they will tend to be quite a lot wide indeed as well. And this is a ventricular pace rhythm, in fact. Yeah. So what is happening over here? This is very interesting ECG as well. And it can be a little bit tough.
ST elevation.
Okay.
Is it? Ventricular bigeminy. With two different QRS complexes that basically alternate.
So you all are going in the right direction indeed. I'm so happy. Very nice. So what is happening is, if you look carefully over here, every beat is different, isn't it? Every beat is different. So what is happening is the direction of the QRS is changing. So once it is indeed very nice. So direction of yes. So the QRS, the axis is changing over here. So this is actually a rare ventricular arrhythmia in which there's a beat-to-beat alternation of the QRS axis. And in fact, the QRS axis will shift 180 degrees from the left to right with each alternate beat. And so if there's a patient of atrial fibrillation or any arrhythmia with or digoxin, you must rule it out actually. Or even with someone having a familial CPVT. CPVT stands for catecholinergic polymorphic VT as well. Or someone, even sometimes it has been reported in patients with herbal aconite poisoning, in fact. So this is a patient of digoxin toxicity where we came across this rhythm, in fact. So, what is happening over here? Some bradyarrhythmias, yeah? Okay, for the sake of time, okay, we have already crossed more than 4 hours, 4 o'clock. So what is happening over here? If you look carefully, so I'll give you a little bit of context as well. So yeah, this was the old guy. I would say like he was in his around 90s actually. He came with lightheadedness and not able to walk well. He was getting shortness of breath and all. So then the ECG was done, and this is what you see. So if you look carefully over here, so what is happening is there's a sinus arrest with a ventricular escape rhythm. You know, if you will notice over here, there's a single P wave. There's only one P wave. You can't see over here. You can't see over here. So there's a single P wave which is visible. This is a 6-second rhythm strip. And there's broad complex escape rhythm with a left bundle branch morphology, and the heart rate is around 25 beats per minute. So the left bundle branch morphology, the dominant S wave in V1 suggests a ventricular escape rhythm which is arising from the right bundle branch. I think I made you guys exhausted quite a lot. Let's make the life sometimes simpler. So this is, you all are already masters at this. Complete heart block. RR intervals are constant to each other. PP intervals are also constant. And so sometimes it may be confusing is the PI interval is getting prolonged, and then there's a missed beat over here. So it will indeed. So it will be exactly not a complete heart block, but a Morbid's type 2 block, type 1. Yes, indeed. So what is happening over here? This is a simple one. You all know it. Let's go to the next one. So this is what we already spoke about. No. This is the other one. RR intervals are regular, PP intervals are regular, and not related to each other. So that was a complete AV block. What is happening over here? Okay, let's try to have a systemic approach. Sinus P waves, PQRST, PQRST, PQRST. Even when we look at the lead one, V1 as well, it looks normal. PQRST, PQRST, PQRST is going fine. Now let's follow the rhythm. PQRST, PQRST, PQRST. Ooh, what is happening over here? Where's the P wave? P wave comes over here later on, yeah? It comes between the QRS and the T segment. Then over here again as well, PQRST, PQRST, PQRST. Ooh, where is the P wave here? Again over here, it comes in between the QRS complex and the T segment. So what is called as the sinoatrial exit block? It happens due to the failed propagation of the pacemaker impulse beyond the SA node, and the sinoatrial node continues to depolarize normally. However, some of the sinal impulses are blocked before they can leave the SA node, leading to intermittent failure of atrial depolarization, what is called as the dropped P wave. Okay, so that is what is called as the SA exit block. So a lot of times what will happen is we will come across such kind of ECGs and we will be thinking, oh, this patient may need a pacemaker. Okay, looks like this and all, what to do. So what is happening is this is like a broad complex tachycardia, in fact. and there's a atypical left bundle branch block here. If we look at the carefully at the V1 and V6, so this looks like a left bundle branch block, but pretty wide QRS, and you can't see the P wave as well. So for such kind of patients, you must try to do the electrolytes. So that patient, you waited for like another. In the meantime, what had happened is ABG you sent. ABG machine was not working, so it was already. I would say like. So you sent the sample to another department. So now it is already. In the meantime, someone had forgot to bring the ABG. You repeated the ECG, and this is what you got. So what is happening over here?
Sine wave.
Very excellent. Excellent thinking indeed. So as you may notice over here, there's huge peak T waves, sine wave appearances there as well. In fact, when the ABG arrived, the potassium levels was 9. So it was secondary to actually a case of rhabdomyolysis. So sustained VT is one of the things we all have to be really careful, and these patients can deteriorate quite a lot. And this are the ones, as I had said, it like so primary angioplasties, the way in which they're done, similarly also to primary ablations as well at some of the labs. So they will take these patients. Yeah, you can try with those medications, trying to treat the electrolyte abnormality, antiarrhythmic drugs as well. Magnesium, as I had already said it, you can try to give. And before trying to using as a temporary pacemaker bridging, you can even consider isoproterenol, in fact, as well. And sometimes you may consider using phenytoin, okay, but without or avoiding the dextrose, in fact. And if there's a pause dependent, VT and all, you may consider to put up a temporary wire as well. This is a very interesting paper which I came across. It is a nice decision algorithm which says that out of four leads, 1, 2, V1, and V6, if more than 2 of them is negative, 90% of the times it will be VT. Okay? Yeah, so it has to be at least 2 more than. If it is more than 3, it is even better. Yeah, but as I said, it is always, see, this is like a shortcut. So try to go through the algorithm, those signs which we spoke about, the QRS width, the Brugada sign, Josephson sign, the notching of the S wave. You should try to see the AV dissociation as well. There are a lot many more algorithms as well which we all try to follow. What we try to learn was on the basis of the QRS width as well. We can divide them into narrow complex tachycardias, broad complex tachycardias as well. How do they respond to the maneuvers, in fact? So that is also quite a lot important. So another maneuver which is there is what is called as modified Valsalva maneuver. Modified Valsalva maneuver is very, I wish I could have shown you a video. In fact, the SVTs, at least 70 to 75% of the SVTs, you can convert them into sinus rhythm if it is a SVT. It is a great maneuver, really. I have seen amazing effects, I would say. So even patients of atrial tachycardia as well, if you do it well enough, if there is a role of slightly also AV node, you will be able to control the arrhythmia, in fact. So modified Valsalva maneuver, I would really encourage you all. So hopefully next time or sometime other, if there will be more time, we can discuss about those things in more details. So to summarize, whenever in doubt, treat a broad complex tachycardia as a VT. Try to remember those signs which will point you towards the wide QRS tachycardias, about ventricular tachycardias and all as well. And do not forget the maneuvers. Maneuvers are very important. Yeah, thank you so much for listening. I'll be happy to answer if there are any further questions.
Thanks. Just a quick question. For patients coming in with AF less than 48 hours of duration, what are the current guidelines on low molecular weight heparin given prior to electric cardioversion?
You can give them this thing, low molecular weight heparin, and you can also consider them for cardioversion as well. That's pretty fine.
So how much?
However, if it is more than 30 minutes, other thing as well, if it is a 12 lead ECG has been done, you have been able to record AF, you must, and the CHA2DS2-VASc score is high, you should consider them to give, and if it is a non-valvular AF as well, you should consider them starting on an anticoagulation.
I'm sorry, my question was specific to pre-electrical cardioversion. How
Yes.
much low molecular weight heparin would you give? Is it a treatment dose or prophylactic?
Give a treatment dose.
Okay. Thank you.
Thank you. Any further questions?
I think we are getting late now. Thank you, Dr. Narendra. We will keep another session. It was so useful. So much we learned today.
My pleasure indeed. I will try to share a recording of this session for the benefit of everyone as well.
Thank you.
Thank you.
Take care. Bye-bye.
Bye. Thank you.